Thank you so much. But I would, before my talk, thank you very much for introduction, kind introduction. But before I would like continue, Peter, your point that we must vaccinate our patient, our people with diabetes is very, very important. But how we can get this, who help to us, like a healthcare professional, is also my subject. In this case, we have a lot of pharmacists, because not too much doctor endocrinologists who have a lot of patients, and it's not possible all the time speak every month and sometimes, but who can do this? Pharmacists. And International Diabetes Federation, we collaborate with Pharmaceutical Association, Federation in the international world, make tools for pharmacists how to do this, what is need, which vaccine need, and this is very important because patients go to pharmacy every day, and a pharmacist can ask about status and recommend this, and then he go to doctor. This is very important collaboration with pharmacists who can assist doctor. This is what I would like to add to your very important point. And now I go to my speech. We will speak about, first of all, I forgot. See, first of all, I'm very happy with you. Thank you very much to Diabetes India, to all of your team, and especially Dr. Banshi Sabo. Diabetes India is the best congress in the world. You know, I'm absolutely sure. It's not compliment. I am from IDF. I must be say that IDF, but now maybe this in Bangkok will be best. But now in the first position, Diabetes India. Yeah. And today we will speak about cost effectiveness diabetes care. I will try make specific practical solution for your practice. It's not easy a topic because you know we have a lot of drugs, and it's sometimes we lost and miss what we can do, and also a lot of new product. If you look in burden of expenditure of economic impact on diabetes, you can see how during the last 15 years it was really increased. And indirect costs consist 35% of annual global health expenditures. And we have some model built using epidemiological and demographic data, as well as recent gross domestic product for a cost for 180 countries. And this model show that global economic burden of diabetes in adult projection from 2015 to 2030 will increase from $1.3 trillion to $2.5 trillion. You can imagine, I don't know what is, how it's money, but how much is money, but this is terrible news. But before we will speak about cost effectiveness, we must know something in terminology of pharmacoeconomic. I only kindly remind your knowledge that what is direct cost, we know the service, drugs, medical supplies. Indirect cost is everything include related to patient care, and incremental cost effectiveness ratio we use for dedicate difference in cost divided by difference in outcomes, and a very important quality adjusted life year quality. Now, this is a measure of disease burden, include both quality and quantity of life lived. It is used in economic evaluation. It's very many research do this like specific point about quality, because quality equates to 1 year in perfect health. And as I say, availability and affordability of medicine. And availability is like what we have on market, and affordable what we can use really, like economic aspect. Evaluation, economic and clinical burden. You see, it's only one example in Sweden. They evaluate this And they see that it's very substantial, but could be reduced by early and effective treatments to achieve glycemic target. Without discussion, we know everybody that complication prevention and glycemic control are the most effective ways for save money. And if you see, this is a lot of evidence we have already seen. If you look 30 years cost effectiveness and alternative strategy of achieve excellent glycemic control in type 1 diabetes, is also show to us that less HbA1c, less complication, better quality of life, and this is bring to its goal to cost effectiveness. If you speak about type 1 diabetes and they use insulin, the use of intensive insulin and devices as a general treatment strategy will reduce the cost effectiveness of intensive therapy unless they achieve better clinical outcomes. But at the same time, another research shows that cost effectiveness of intensive glycemic management depends of age and duration since the diabetes diagnosis. Intensive therapy using pump with GCM is not currently cost effectiveness as general treatment strategy because of course it is a big cost of this equipment. Pump therapy with CG may still be an appropriate therapy for selected patients to have poor glycemic control and problematic hypoglycemia and who achieve improved long-term outcomes with such therapy. But I would like to add something from my side, which I know exactly because I'm a person with diabetes and use different devices during my 30 years with diabetes. And of course, we must think also about mental status of patient. It's technology completely change the status and a person more free, feel free in life. And now practical solution. And if we speak about some drugs, semaglutide versus insulin aspart, that 1 weekly semaglutide in 1 milligrams projected to be high cost effective versus insulin aspart in treatment type 2 diabetes in the UK was. If you look in CGLP-1 semaglutide versus dulaglutide, liraglutide, we see that oral semaglutide is predicted to offer health benefits similar to substantial semaglutide ahead of dulaglutide and liraglutide. Oral semaglutide is cost-effective GLP reception agonist treatment option. Another long-term cost-effectiveness study is semaglutide 1 milligram versus dulaglutide 3 and 4.5 milligram also was in the UK, shows that semaglutide 1 milligram represent a cost-effective treatment versus dulaglutide is this dose of 3 and 4.5. In UK this was. Semaglutide small dose like 0.5 milligrams and 1 milligrams versus dulaglutide 1.5. Compare with treatment with dulaglutide, once weekly semaglutide represent a cost-effectiveness option for treatment individuals who cannot achieve glycemic control with metformin. Another small dose research in Japan shows that one semaglutide in small dose in cost-effective treatment option compared with 1 weekly dulaglutide 0.75 milligram. Look, combination. We spoke about combination in great session about primary care, and we see that oral semaglutide plus metformin seems not cost-effective versus empagliflozin plus metformin in patient uncontrolled in metformin. This is we can also must know and your choice. Semaglutide versus sitagliptin, emagliflozin, and liraglutide. Oral semaglutide was estimated to be cost-effective compared with liraglutide versus sitagliptin, and background there alone, but it did not meet their hold compared with empagliflozin. Cost-effectiveness analysis of dapagliflozin in treatment high-risk patients with type 2 diabetes in UK. Compared to placebo appear to be cost-effective. The finding highlights the potential of dapagliflozin to have a meaningful impact in reduce the economic burden of type 2 diabetes, and this is of course associated with complication. Cost-effectiveness analysis of empagliflozin therapy that shows that it's better. Empagliflozin, in addition to standard care, is projected to be high cost-effectiveness study in UK. And if you speak about CGLT-2 for type 2 diabetes, and this is make the cost effectiveness compared with many antidiabetic therapies, includes DPP-4, sulfonylureas, thiazolidinase, alpha-glucosidase inhibitors, and insulin even. GLP, CGLT-2 and DPP-4 versus more oldest therapy, of course, it's more cost-effective. If you see, demonstrate also, this is, you know, it's you listen a lot of lecture about reduction of cardiovascular and renal complication if we use CGLT-2. Cost-effectiveness CGLT-2 versus GLP-1, DPP-4, another, it's a review. The study that discovered that, of course, CGLT-2 was more cost-effective than GLP-1 in type 2 diabetes. Another example is not about anti-diabetic drugs. It's about another, that for primary prevention, statin use has been found not to be less cost-effective like prevention, primary prevention. Another bariatric surgery was cost-saving among individuals with type 2 diabetes and overweight, likely due to larger health risk posed by obesity. This is what I did in Ukraine. It's my subject, like pharmacoeconomic, and we have many medicine in market. It's available, but if I account affordability, it's not too much. And this case, we have a lot of medicine, but finally we cannot implement modern schema. This is a big gap. And another aspect which also influence on economic burden and cost effectiveness. This is medication adherence. As you see, a 20% increase in adherence can save 1,070 in total healthcare spending for each patient type 2 diabetes. It is important to educate patients that saving money today but not adherence to the treatment may mean spending much more money in the future. This is like in dancing. Physical, and this is also interesting. Everybody speak about mental health and how psychology can help to us, but you see, for type 2 diabetes, there was evidence psychological intervention improved dietary behavior and quality of life, but not blood pressure, body mass index, or depressive syndrome. This review suggests that psychological treatment offer minimal clinical benefit in improving HbA1c level for adult type 2 diabetes, and the researchers cannot find any evidence that any benefit, clinical benefit with control intervention in improving HbA1c level for type 1 diabetes. Economic about safety. Globally, the cost association with medication errors has been estimated at US 42 billion annual dollars. And you see, it's a very important safety, and it's a lot of resolution about patient safety. This is also we must thinking about this, and when we prescribe. About therapeutic inertia. Achieve early and intensive glycemic control therapy. Minimizing therapeutic inertia can lead to substantial saving for society, ranging between 9.6 million to 51.4 million euro. This is a big problem, like therapeutic inertia, and finally, this is like slide, this is complex, which influence on cost effectiveness, like safety, adherence. If it's adherence, you must provide good consultation. I would like recommend read this or listen in other our colleagues which have already presentation about good consultation, Dr. Rashid Kasari, and about inertia, clinical inertia. Balanche Chidambaran, sorry if I'm not right. And of course, price of insulin and glucose lowering drugs. This is a very important issue, and this is what we work on this in a global level with WHO, with manufacturer, and this is a lot of stakeholders must be together for decrease price, because without this we cannot deliver to all people who need diabetes, who need drugs. Biosimilar is one way for reducing on price human and analog insulin by increasing complication. As member of European Medical Agency, which subject of biosimilar, I recommend go to this site, and you can find very practical recommendation for you, and also material which you can use for consultation people with diabetes, because they provide not only for healthcare professional guidelines, but also material for patient about biosimilar. It's more easier because, you know, sometimes they reject, they afraid this biosimilar because it's not enough knowledge. We must also provide this knowledge. It's one option for decreased price. Decrease of cost way for prevent adverse consequences of diabetes. It's promote awareness about diabetes, promote lifestyle change and patient education. You see that the use of diabetes self-management education is associated with low total medical cost and low total prescribed medical cost. And pharmacists, again, this is, I would like strongly recommend make cooperation with pharmacists. Use this cooperation because it's make easier your work. They only help to you. And I, like Peter say, invite you to our Congress. And this is on this Congress, it will be the first time section about pharmacists in diabetes, but it's not about them role, about how we can collaborate, how we can do together and achieve better outcome for people with diabetes. Thank you very much for your time, and if you're interested in this economical research, please ask me. I will be happy to help because this is my subject, and I'm sure it will be very interesting collaboration. Thank you very much for your attention. I'm in time.